Great. I can see people trickling in from online, which is fantastic. Just get people set up in our Zoom room and get started in just a second here. Um, I'd like to thank everyone for joining us, coming out today to our CPE speaker series. This is our first session, actually, coming back into the academic school year here at the University of Toronto, which is where I'm based. And so my name is Annalise. I am the administrator for our Center for Practice Excellence. And just acknowledging that some of those who might be joining us for the first time today, the Center for Practice Excellence is based out of the Leslie Dan Faculty of Pharmacy here at the University of Toronto. And one of the things we focus on is pharmacy education and training, research and practice and innovation. And so these monthly speaker series events, which take place every month, throughout the year is really where we get to learn about and from each other to discuss critical issues impacting the future of healthcare and pharmacy. So although we are based at the Faculty of Pharmacy, our scope goes much beyond that. And just before we jump into today, I'd like to get us started by acknowledging the land on which the University of Toronto operates, which is where I'm located today. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. I recognize that this meeting place is still home to many Indigenous peoples from across Turtle Island, and I'm always very grateful to have the opportunity to work and learn on this land along with all of you joining us today. So I am extremely pleased to have Erin, Sherilyn, and Rosemary joining me for a presentation and discussion today on the role of lay vaccinators. We have about 30 minutes dedicated for a presentation by Erin and then remarks by Sherilyn. And then we'll have about 20 minutes for audience Q&A with everyone online with us today. So I'll sort of cue you at the end of the event where we can get started with that. But just briefly for a few very quick housekeeping items, I'd just like to remind everyone that these sessions are recorded and posted online on our CPE YouTube channel, and then also on our Faculty of Pharmacy website. I'll just ask that folks keep themselves muted, but cameras on if you would like to. And just put any questions and comments for Sherilyn or for Erin into the chat. We will get to those at the end of our presentation time today. So with that being said, I'd like to introduce Rosemary Killeen as my co-moderator for today's session. Rosemary is the Director of Lifelong Learning at the School of Pharmacy at the University of Waterloo. In this role, she oversees the design and development of professional development programs for pharmacists and other healthcare professionals, and also acts as editorial and operations lead for the Pharmacy 5 in 5 project, which I highly recommend checking out if you have the chance. A graduate of the University of Toronto's Faculty of Pharmacy, Rosemary also holds a postgraduate certificate in public health from the London School of Hygiene and Tropical Medicine. She has practiced in settings including primary care and community pharmacy, and also served as editor-in-chief and deputy publisher of the Canadian Pharmacist Journal. I'd like to pass it over to Rosemary now to introduce Erin and Sherilyn.
Thank you very much, Annalise, and I'm very pleased to be here today to join everyone and particularly to introduce our two expert panelists. First, I'd like to introduce Erin Orkin. Dr. Orkin is a family, emergency, and public health and preventive medicine physician and scientist. He's an associate professor in the Department of Family and Community Medicine at the University of Toronto and an associate clinical professor and head of the Department of Hospital and Institutional Care at Toronto Metropolitan University School of Medicine. Dr. Orkin is Ontario's first fellowship-trained clinical public health specialist, and he's dedicated his career to developing and studying health services at the intersection of public health and clinical medicine. With a focus on developing programs to address health inequities, his work advances strategies to engage and involve lay workers and the general public in delivering care and building more resilient, sustainable, and distributed health services. So welcome, Dr. Orkin. We're also joined today by my colleague, Dr. Sherilyn Houle. Sherilyn is an associate professor at the University of Waterloo with interests in pharmacy practice to full scope, particularly in areas of immunization and travel medicine. She regularly publishes research on pharmacy practice and immunization and has coordinated the injection training curriculum at the University of Waterloo since 2015. has also authored multiple injection training programs for practicing pharmacists and pharmacy technicians, and reviewed injection training programs nationwide for the Canadian Council for Continuing Education in Pharmacy. So at this point, I'll turn it over to Aaron for him to take over with his presentation.
Thank you so much. Let me just do a little bit of IT work here, get my slides sharing, and then we'll get going. So while I get going, I'm going to ask everyone attending to sort of reflect on some concepts. I recognize that we're gathered here today because we're within the structure of academic pharmacist space and thinking about the full scope of pharmacist work. And in that context, I think it's really exciting to think about immunization and think about access to immunization for the general public. Can you see my slides at this stage?
Yes, thanks.
Perfect. But I want to start with a little bit of a provocation, a little bit of a question for you to reflect on as I share my slides, which is that in a sense, there are two different approaches we might take when we start thinking about the community of different health professionals and access to immunization. On the one hand, we might say we want to get the whole public immunized, and therefore on this journey to increasing public access to immunization, we would say that more regulated health professionals ought to be engaged in immunization. We ought to involve all health professionals, as many as possible, in the delivery of immunizations and increase the scope of practice within the space of regulated health professionals. That's one approach. That's something that I'm interested in. That's something that I've been involved in, and that's something that we can reflect on. Another possible approach is to say we want to get the general public access to immunization, and so we should talk about radically changing how immunization is thought of in our communities from something that is highly professionalized and that might be something that regulated health professionals bicker about to something instead that is radically public, where we say that the general public seems to have access to immunization, that we are moving immunization from something that is seen as highly professionalized, highly regulated to something that is much, much more accessible and that starts looking a bit more like first aid for prevention. These might be approaches that can go hand in hand, but I'd ask you to reflect on whether or not these might also be approaches that could find themselves at loggerheads, and that advancing one approach to improving immunization access for the general public might actually get in the way of the other approach. So I'll just leave that for reflection. My talk today is about immunization program myths and what they might teach us about lay vaccinators. And I hope that by sharing some myths and exploring them, we might reflect on that broader question about going the professionalized route versus the lay and deprofessionalized route to increasing public access to immunization. So myth number one. I'd like to start by proposing that vaccination is mainly about who is licensed to put needles in arms is a really important myth. I think everybody on our call today knows that this is a myth. We know that immunization and immunization programs, even once we've worked through the process of developing immunizations, developing public awareness of immunizations, developing willingness to be immunized, developing regulatory structures, even once you've done all of that, there's still a lot more than putting needles in arms. It's about distribution and cold chain, messaging and advertising, dimensions of consent, documentation, community engagement, responses to misinformation, issues of access and equity, questions of location, options and variety of immunization choices, so public awareness about the de-standardization of immunization practices, not just internationally, but across quite a local jurisdiction, adverse event management, reporting, and quality assurance. And then once we've navigated all of that, it is about putting needles in arms. And I think that it's important when we're thinking about immunization programs, especially since we tend to find ourselves in discussions where we use these shorthand terms and say, this is really about putting needles in arms, to remember that it is indeed much more complex than that. But at the same time that it's a whole lot more complex, there is the tremendous challenge that is real of that final bullet, that getting needles into arms and getting immunizations into people is still itself quite a complex operation and something that does actually challenge us in terms of scale up and in terms of access. Perceptions about how complicated this is or how simple it is also gets in our way. When we get really apt at talking about just how technical a procedure this is, gets in the way of simplifying it. When we get skilled and fluent at talking about how simple this procedure is, it might become more accessible. Myth number 2, before COVID-19, Canada's vaccine programs were generally safe and equitable. I think that the pandemic, well, we could debate whether we would even be having this webinar today or whether this topic would even come to light without the pandemic. I think that those who are working squarely within the space of immunization were seriously concerned about issues of equity and safety prior to the pandemic. The idea that we could hold a webinar about it, or that the general person walking down the street would be aware of issues of equity in vaccination, I think is very much thanks to the pandemic. But what follows from the belief that things were safe and equitable is the belief that the COVID crisis is behind us and that we have some hope to go back to those before times of the pandemic. But I think we need to look at this myth quite carefully. Prior to the pandemic, we had very low flu immunization rates and quite tragically low routine immunization rates outside of flu. We had routine deaths and morbidity especially among marginalized populations from vaccine preventable diseases. This included meningococcal deaths among people experiencing homelessness, hepatitis A outbreaks among people injecting drugs, unvaccinated Indigenous children in remote communities, older adults who were routinely hospitalized due to vaccine preventable and especially pneumococcal disease. And right in the midst of the pandemic, we struggled with Mpox vaccine programs and outreach to particularly marginalized communities. And prior to the pandemic, we also had a total absence of scalable and scaled mRNA vaccine technology, which made it even possible to rapidly produce vaccines at the kind of volumes necessary to create sudden and massive needs for immunization. All of that has come to light in the context of the pandemic. And so the need for equitable and safe vaccination programs that cover all of those bullet points I described earlier, but that also are really good at putting needles in a lot of arms, I think is now much clearer. In that context, I want to come back to that provocative question that I asked at the beginning. I believe, and I am forthcoming in saying that I share this with you in the hope that we can generate some discussion, that I've created this slide to highlight the kind of what I see as entrenched bickering between regulated health professions about their scope. I'm a member of the Ontario Medical Association. I'm a physician. This presentation runs completely counter to the biases you might think would come from that. The OMA proudly says that they're working to protect the practice of medicine against scope of practice encroachment that may threaten patient safety. That's a very strong belief that says that the best way for the public to get safe vaccines or many other kinds of medical care is through doctors only. Meanwhile, you have organizations like the Canadian Pharmacists Association, who I think is represented on the webinar today, with images like this that are clearly strategically about exploring ways to expand that scope in jurisdictions where that scope is too limited, and celebrate those environments where scope has been expanded. What I want to emphasize is that I think this entire argument, this entire space of debate is counterproductive to the real possibility of getting vaccines to the level and scale that is possible through late immunization. Myth number 3. The main driver for new vaccine providers is to cut corners, downskill to save money, bust healthcare unions, and push real experts out of their job. This has nothing to do, the possibility of lay immunization and lay providers really has nothing to do with protecting highly centralized professional-centric practice. If the leaders and voices from marginalized communities, racialized communities, Indigenous communities, people who use drugs, and other groups that are made so peripheral are truly experts in their own health, we need to find ways to open the doors for people from those communities, not just to serve as ambassadors or peers in encouraging members of their community to access essential health services, but to actually be able to deliver those services directly themselves. And so there is a paradox in speaking the language of equity while also speaking the language of protectionism for our professions. Myth number 4, vials, needles, and syringes can only be used safely by health professionals. In my own short career, I have seen numerous artifacts and technologies of healthcare evolve from something that was initially seen as highly protected, that could only be used by professionals, to something that could be used by anybody. I've shown some examples here, ranging from tourniquets for first aid through to naloxone kits for opioid overdose, and more classic examples such as EpiPens. We know that with appropriate technological design, appropriate engagement with medical device engineers, and appropriate public education, we can take both pharmaceuticals and the technologies used to deliver them from something that is seen as entirely restricted to health professionals to something that is so commonplace that you would find it in the lobby of a hotel, behind the counter at a convenience store, or in a university dormitory. And the idea that vaccines, which I've put at the middle here, are just completely outside this realm of possibility, I think is quite mistaken. Myth number 5, existing professionals can reach everyone safely, equitably, and effectively. We know from such beautiful historical examples, such as the Freedom House Ambulance Service in Pittsburgh, that in order to reach communities that are structurally excluded from mainstream healthcare, that it is necessary to engage members of those communities. So this was the first ambulance service ever created in the United States. It was born because members of the Freedom House community, a predominantly Black community, were unable to access emergency care when they needed it for fear of police engagement. The solution was not to encourage new professionals to come into the environment, not to encourage people to take bridging roles or ambassadorial roles, not to engage peer workers to bridge the relationship between police forces and Black communities. It was to train locals in the community to provide first response, which was utterly transformative. So who can we train from communities to deliver vaccines rather than drawing existing professionals into those communities? So we gave this a try during the pandemic. The idea was radical, and a much simpler idea was possible during the pandemic. What you have there on the left is the Freedom House Ambulance Service, and I just found it so fascinating to see how similarly composed this photo was of our lay vaccination clinic at the University of Toronto, with students with undergraduate training only, no healthcare experience delivering vaccines. And I'll close just by saying that we developed this program, we published some results, and the only thing you need to know about lay-run vaccination clinics is that there is nothing radical about lay-run vaccination clinics. They are completely mundane clinics that look like any other clinic, and roughly 95% of the people who attend them say, I had no idea that this was meaningfully different to anybody else giving me my vaccine. It's entirely the same experience as nurses, doctors, pharmacists, or anybody else putting a needle in my arm. We had roughly 12 lay vaccinators supervised by one nurse or physician. And I would like to dream that scaled to a much greater extent, supervised by pharmacists, physicians, nurses, or otherwise, that we could reach many more Canadians by positioning the lay public to deliver the vaccines. Thank you.
Thank you, Aaron. Lots of interesting things for us to think about there. I'm going to call now on Sherilyn Houle to give a few remarks in response.
Thank you so much. Just do a quick audio check. Is everything working? Yes. All right. So I have a couple notes that I've obviously jotted down as I've been thinking about this the last few days. But I think the first thing I want to draw attention to is actually Dr. Orkin's closing comment, which is a reassurance that there is oversight, right? Lay vaccinators, peer vaccinators, there is a regulated health professional that is there to do what is, clinically within their scope, or to assist in the event of an emergency, or for, more challenging scenarios or whatever. So I think that provides a lot of people reassurance that they're handling the technical task of handling the needles, administering the vaccines, right? That is very teachable. It is easy to learn. We teach it in the first year of our program. Like, our students that are learning it are much more on the spectrum being still a member of the lay public much more than they are at the point of being a licensed healthcare professional. And if we can provide that training that early in our program, and I know the same thing happens in other programs. My husband's a former paramedic and they learn that very early on as well. So I just wanted to bring that forward as well, that it's not without standards and procedures and oversight and the presence of that healthcare professional. And when I was thinking about this further and preparing to hear Dr. Orkin's perspective, I went immediately to predictors of vaccination uptake and which of those predictors can be influenced by having lay and peer vaccinators. And so I went to the 5C model of the psychological antecedents that predict vaccination. And for those of you that aren't familiar, that is complacency, which is thinking that you're not at risk of the disease that the vaccine is preventing. Convenience or constraint. So can I get to it? Can it get to me? How am I able to actually access that service? Confidence in the vaccine itself, as well as the systems and people delivering it. Calculation, which is that information seeking to make a decision related to vaccination, and then collective responsibility, or that willingness to use vaccination to protect not only yourself, but others around you who maybe cannot be vaccinated for whatever reason. And initially, I thought maybe 2 or 3 of these would be directly impacted by the greater use of lay vaccinators. And it didn't take much thought at all for me to realize really all 5 of those can be positively impacted. And I'll explain kind of my rationale there. So on the complacency side of things, I think there's lots of people who realize that our current healthcare system is quite strained, quite burdened, and I think people feel guilt about accessing a health professional's limited time when they know there's so much on their plate and their workload, and so many other patients that need their care. And so I almost wonder if people might feel less of like they are being less of a burden to the system if they're accessing it via a lay vaccinator type of environment versus going into a clinic and taking up a appointment time per se. And I also think that I would, myself say that, well, if my peer or another member of the public thinks that this is important enough that they're willing to provide their time to contribute towards, it must be for a reason, right? So I think there's reassurance in that helps to overcome some of that complacency. I think convenience is probably the easiest one to have imagined. I'm thinking about, for those of you that watch hockey and, Rogers Arena in Edmonton offering flu shots in the lobby as people are going in and out of the hockey game, right? The efficiency and the health system capacity is expanded so much by having that model where you've kind of got the hub and the spokes. You've got the supervising healthcare professional, and then you have the lay vaccinators that are the ones doing the actual injections. And I can only imagine, you're reaching people where they are. They're not going out of their way to find you. You are going to find them, and you've got that efficiency built in. I think confidence is a really important one, especially when we're talking with people that maybe had a negative experience with the health system before. Maybe there's systemic biases and mistrust and things that could be a barrier holding them back. I think if they see a peer, being the person administering the injection, it creates that sense of security and confidence more so in the system than they may have had if they're interacting with a more traditional model of that. The calculation part was a little bit more challenging. The thing I was thinking of for that is that, vaccination has become, I think in the last 5 years, probably post-pandemic, a much more emotional decision than I think it used to be. I think we've got, political things involved. We've got social, pressures, and whether your friends and family are in favor versus opposed. And I think there might be more comfort to share that with somebody who maybe isn't in that healthcare professional role as well. And I think that factors into that calculation of whether I want to be vaccinated or not. And then going to that collective responsibility, a question that I got very often in practice that was really quite, I think, meaningful to these conversations was, are you vaccinated? Did you get it yourself? Do you vaccinate your children? Right? And I can confidently say yes. And I'm doing that not only to protect myself, but to protect you and all of the other people that I come across. And I think that having, peers vaccinating peers, it creates that sense of collective responsibility as well, that they are doing this to help you and your community and your loved ones and your circle just as much as they are for any reason for themselves. And then my final thought on that was we always want our care and our outreach to be patient-centered, right? That is the goal, is to reduce the burden of complications from vaccine preventable diseases. But I'd be really interested in Erin's thoughts about how much does it benefit the person who's doing the injecting as well, that lay vaccinator, that peer vaccinator. I can imagine there's many younger people who maybe aren't able to get a job and they can't get a reference letter to then equip them for the next job. And this provides them with some hands-on experience that they can use towards a future job. I'm thinking about people who are maybe retired and want to still maintain a connection with their community for that sense of purpose. Perhaps people that are thinking of going into public service professions. Maybe they want to be a police officer or a first responder, maybe a health professional. And this is a great opportunity to contribute and give back to the community while also reaching that goal of prevention of vaccine preventable diseases. So I'd be very interested in hearing Erin's thoughts with the student vaccinators, what kind of fulfillment they felt from doing it as well.
Thanks very much, Sherilyn. Erin, I don't know if you have any specific response to Sherilyn's comments, but at this point, we're going to open the chat for any participants to put their comments and questions in for either of our panelists to address. So feel free to send your trickiest questions about lay vaccinators or maybe even other vaccination related questions. So put them
So
in.
let's bring those comments, absolutely. And while people type, I'll make a little bit of space with an answer to that question about benefits for the lay vaccinators. One of my favorite parts of lay health programs or task sharing with the lay public, be it first aid or first responder programs. And some of these are very common programs like, I don't know, the Canadian Ski Patrol or your local team of lifeguards at a local pool. These are lay for first aid programs. They have tremendous benefits to the people who deliver them. And so you get this kind of layered impact on community in that we tend in delivering health services to think about the benefits to the people receiving those health services. Those of us on this call who are health professionals or who are training as health professionals or otherwise, we all know intuitively that delivering those services brings us great personal benefit. Not only is it our livelihoods and our income and our passion, it's also the largest single industry in this country. It's how we put food on the table. And so for marginalized communities and underserved communities, being excluded from healthcare roles is really a key economic barrier as well. So the creation of different entry points into health services, especially for young people, especially for people who don't have access to existing regulated health professional roles, creates more opportunity for involvement and fulfillment through the delivery of healthcare. I've observed that. Certainly, part of the reason why we started this program with students was that these were the student first responders on campus, and they had nothing to do. They were really upset because there was nobody on campus. There was nobody having chest pain. There was nobody to respond to with a bee sting. There was nobody who'd fallen and broken their ankle. And they didn't know what to do. And they were all keen to become nurses and pharmacists and paramedics and doctors. And all you had to do was ask them if they wanted to get a vaccine, and they all said yes. So yeah, there's tremendous benefit there to the individuals involved. And just to follow up on that piece, there's lots of reasons to have a regulated health professional in the room, but at least my experience on this program was that there's many good reasons for it, but one of them is not to respond to adverse reactions and emergencies. You can rest assured that your average first aid provider is more skilled at responding to anaphylaxis than your average health professional. They have it down to a protocolized science. And if you want somebody to respond to anaphylaxis, you're looking for a first aider, not a doctor or a nurse or a pharmacist.
That's great. Thanks so much, Erin, for that. We do have lots of questions coming in. So I'm just going to turn to Lisa's question first. Erin, you spoke with your last slide a little bit about, the 12 or 13 lay vaccinators, one healthcare professional in the room, obviously with this first iteration of the project. Lisa's question is, could you talk a little bit more about what is needed for scale up? And I'll just add on to that to say, could you also share a little bit more with us about some of the logistics that went into setting up the program the first time?
So I'll limit the answer on what's needed to scale up to the sort of strategic elements for those of us who think about health system policy, because what's needed, there are sort of technical elements. We need training environments. We need But to get strategic and say, if we wanted to, deal with another pandemic and have this be a real part of it, I think what we need is regulated health professionals who are trained and comfortable with the idea that delegation is not just something interesting that they can do with their job, but something that is truly part of their job, to deliver services that are at the bottom of their scope, like putting needles in arms, without delegating it and supervising teams of people who are doing it on their behalf, I think is below our capacity as regulated health professionals and should not be permitted. So we need to see movement from the educational right through the regulatory space to really say, it's not just that you're allowed to delegate things, it is your job to figure out how to delegate things. And I send that message to nurses, to doctors, to pharmacists, to otherwise. You should be running teams, not just doing this yourself. We are far too trained to be drawing up vaccines and delivering them one at a time. We should be dealing with a team. We need clarity on the delegation policies that enable that. We need clarity on the remuneration policies that would go with that. So, for example, I can make a living giving vaccines one at a time. Actually, I can't, but I can get a fee for it. But there is no fee available if I supervise 1,000 lay workers giving vaccines. There is no mechanism for me to build that. So we need models for that. We need some policy movement in that although the structures of delegation for those regulated health professionals that are allowed to delegate produces very good models for safety from medical legal risk for those peers, there are still general liability issues that needed to be navigated. So we had to figure out how to appoint those peers and how to ensure that they were insured. And that's possible, but we don't have really nice fluid mechanisms for it. So these are some of the sort of regulatory and policy dimensions that I think need to be addressed. And there's lots of technical elements needed for scale up, but this I think would make it a professional kind of norm to start doing these things. The technical aspects, to answer your second question, are no different to running any other vaccination clinic. If you want to put 100 people through a room in the morning, you're going to need 10 professionals, somebody to drop the materials, some safety equipment, you're going to need all of the trappings and expendables of delivering vaccines. It's no different if you're dealing with peers or lay workers. You need the same stuff. But the technical elements of running a lay vaccination service are no different to running a regular vaccination service. And for everyone's knowledge here, especially since everyone here is so familiar with Michener and the type of education that is used for either nursing or pharmacist training on the delivery of an intramuscular injection, we used the exact same module for these lay workers. We just borrowed it from Michener. They had no difficulty understanding it. And no difficulty taking the module. So they received the exact same training as a first-year nursing or pharmacist student would get.
Oh, thanks, Aaron. That's great answer. Very, very thorough. I really appreciate actually just hearing some of those elements. The next question online is from Shelley. Her question is, where do you each see the line between increasing access and maintaining clinical oversight? And who should be accountable for quality and safety in that expanded model? So perhaps getting back to some of those regulatory elements you touched on, Aaron.
So I find it, given that this is my area of work and research, and it's not just about vaccination, but it's about lay access to a number of essential health interventions. I find it fascinating that somehow regulated health professionals, our advocacy bodies, and our own professional identity has somehow managed to internalize the idea of responsibility for quality and safety of the patient receiving care in front of us, and managed in the same breath to feel no responsibility for the people who simply can't access immunization or who don't walk through the front door. My job as a public health physician is to always think not about the people accessing care, but to worry about the people who are not accessing care and think, what are the health effects for those people who are not accessing vaccines, who are not accessing primary and preventive care, who don't have access to safe water or good food, et cetera, et cetera, et cetera. The balance here, to answer this question, of finding that line, I actually think comes when, as individual professionals and in working with our advocacy and regulatory bodies, we do the deep work of internalizing that problem and saying that I am equally responsible for the safety of the person in front of me and for all the people through the mechanisms that I've put in place to make it so safe and so perfect and so optimized, but I can only see 12 patients this day. And all of the people who, as a result, don't get a vaccine, and to really feel responsible when they have an adverse event related to the fact that they suffer from a vaccine preventable disease. When I see regulated health professions bearing responsibility for that, I think the line will move. And I think we will say, wow, we really need to increase access radically, because we are truly responsible for the people who were just admitted to the ICU as an older adult with COPD for pneumococcal pneumonia, who never had their pneumococcal vaccine, picked up a prescription for their COPD from a pharmacist, got it prescribed from a physician 6 times in the last 2 years, and never got a pneumococcal vaccine. I would like to see the pharmacist and the doctor held responsible for that. And then you'll see the immunization rates go up.
Sherilyn, are there other thoughts you'd like to add to that question, or Erin's thoughts?
Yeah, I kind of am seeing a lot of this in the pre-pandemic, post-pandemic shift, right? And so I think that, like we're talking about now, and maintaining, taking care of the people that are accessing our services and also getting to the people that are not. I think that we live in a much different world now where convenience is trumping a lot of other factors, right? If it's not something that's easy for people to do because they're already working 2 jobs, they can't afford to pay for things out of pocket. There's, those societal pressures. I think that makes this environment a lot different than it used to be. And so I think that this is a new model that can evolve alongside that a little bit. Our old practices, like Erin said earlier, weren't all that great. They're definitely not great now. So I just kind of wanted to highlight that to me, it's almost like a very clear distinction. And if it wasn't working then, we have a completely different society now. It's absolutely not working now. And we need to be innovative, and we need to get those systems that, able to accommodate, legislatively, remuneration, all of those things to this new reality that we're in. And so I just really wanted to commend Aaron for his, spearheading this through and bringing this up. I really think at the right time, because we need all hands on deck to get to people a lot more than we used to.
Sherilyn, we are in the era right now, and everybody's heard this, everybody's seen it online, everybody sees the effect that it's having both on public health and on public trust in healthcare, which I capture this under the title of do your own research, which is the massive erosion of trust in expertise broadly, but trust in healthcare and public health. What I see baked into this really excellent question around where do we find that line around safety and otherwise is that I think that we are missing as professionals that the general public does not put a huge amount of trust anymore in the idea that those regulated health professionals are just there to protect your safety. There's a huge distrust in that, and a huge belief that regulated health professionals have used notions of safety and oversight as a mechanism to protect a monopoly, which is also true, and there's plenty of sociology of professions to demonstrate that. Our best hope to get out of this is not more protectionism, because there's tremendous distrust in that protectionism. It's to demonstrate that most of what we know can be taught to anybody, so that if you do your own research, you can get real answers and you can deliver really good care. And so rather than saying the best way for you to get a vaccine is for us to produce highly controlled environments where you get a vaccine from somebody who's extremely well trained, that produces tons of suspicion now. Instead, we should be saying those professionals are doing a great job of making it so that if you do your own research, you can deliver a vaccine to yourself and your kids and your spouse at home. You just pick it up and it'll be really straightforward, and it'll be packaged in a way that looks a lot more like an EpiPen or a Narcan kit or something like that, and a lot less like something that you have to draw up and have all these professional trappings in it, and that it feels like a local healthcare intervention that people have hacked, that people want to be able to feel that they can fully understand and hack it. The professions can do a lot of work to make that safe, and accessible, because going far in the other direction is not working for us right now. People are very suspicious of it. They don't trust us.
Yeah.
And they don't trust that bickering between the regulated health professions either. When the doctors are saying we should only be doing it, the pharmacists are saying, yeah, but we can do it. That whole discussion, the public hates it.
I completely agree, Erin. And that was sort of my follow-up question to that is there's sort of the question of how do we manage this growing misinformation, disinformation in communicating with patients, of whom we all are a patient. But my question was, that's the second part of how do we manage some of the misinformation going on between health professions right now and actually working towards, I think, even just more collegiality in some ways.
Yeah. Well, there's nothing like a bunch of completely unregulated individuals, lay workers in the room to take the edge off. Let me put it that way. Like, I don't have the secret to excellent interprofessional care. I work in an emergency department. It's an extremely interprofessional environment. It's a wonderful environment. It's my favorite part of providing care is that interprofessional dynamic, but I'm not going to sugarcoat or pretend that it's always hunky-dory. There's real challenges. There's friction at those interfaces. And what you're describing of interprofessional challenges are real. What I'll say is that when you throw a bunch of lay workers in the room where it causes everybody to put on their best behavior. And so I think there's a lot to be learned from moments where there's clearly a shared responsibility among a small number of regulated providers to deliver care to a large number of people through a team of unregulated individuals who need to see and feel support from those regulated professionals. That I see as a microcosm of what we want to be achieving across all of society, not just in the lay vaccination clinic. I think the very small number of regulated professionals that we have right now, the data in Canada shows that within the next 10 years, we're going to be over 100,000 regulated professionals short, and that's just nurses, pharmacists, and family physicians. So like that's not even the full scope. There's a tiny number of regulated professionals. The image that the public should be getting is that our shared job is to support you to get the knowledge and skills that you need to drive your own health. Not the only way to be healthy is to come and see us one at a time. It's never going to work.
Sherilyn, any thoughts on that? Just I know in your role also as an educator, pharmacy educator at the University of Waterloo, anything you're seeing sort of with, pharmacy students that are coming up through the system and any differences across years or anything from Waterloo that sort of piques your interest?
Yeah, I think it's been hugely successful to move our training earlier in the program. We used to train in third year alongside training for, prescribing and adapting and all of these, more higher order clinical interventions. Now we do it in first year, right? And we've had zero issue with it. And that to me just reinforces that confidence that this is something that can be easily taught, easily assessed, that higher level clinical knowledge of determining is there a contraindication to this vaccine, that's not even in play at this point in their career, but yet they are going out into the community and giving thousands of flu and COVID shots in their part-time jobs, and we are having no issues with it. This is something that, I've developed injections training programs. We all use the same competencies that Public Health Agency of Canada has identified, and you simply just have to pick out the ones that are relevant to the audience that you're teaching to. So when we're teaching to pharmacists, they learn all 14 of the competencies. When we're developing a course for technicians who aren't going to be providing, patient education and clinical judgment, we scale it down to the 4 or 5 that are most relevant to what they're doing, right? And the same thing could be the case for the lay vaccinators. And, I always tell our students that when they first come into the lab where they're actually giving their first injections to a peer, I mean, the nerves, you cut the tension with a knife. Some people are extremely nervous about it. They know it's part of their job. They're fully accepting of that. But that act of doing something that might cause someone else discomfort, it's a little bit hard to deal with until you do it. And I always preface it by saying that your nerves are absolutely normal and everybody around the room is probably feeling the same way. But this will probably be the most transformative 2 hours of your life, because every single person leaves that training going, oh, that was it? I was so worried about it. That was it. and just that sense of relief for them that, you know, I spent 4 hours studying on exactly how to do this, and then they actually do it and realize, oh yeah, I got this. I can start doing this tomorrow, no problem. It is instant, that sense of competence and confidence to do it. And I've never trained lay vaccinators myself, but I can only imagine it's exactly the same. That, you know, it's once you do it, and once you do it under observation and you know you're doing it correctly, it is that technical checklist type of task, and that confidence is built right away. So I've definitely noticed that in the training I've been involved with.
Yeah. Thanks, Sherilyn. I think it makes me also think a few years ago here at the Faculty of Pharmacy and in collaboration with the Faculty of Nursing, we held a naloxone training program. It was offered as an IPE, so interprofessional education for students, and really interesting to have a bunch of healthcare provider students in the room, some of whom were experiencing a needle and syringe for the first time. But we walked through simulations, and I would really echo what you said, Sherilyn, of people saying, "Whoa, this was a little bit easier than I thought." I got to test, practice after the simulation individually, and I think there's huge merits in just the exposure piece. So thank you for sharing those thoughts. Erin, I can see you did reply to Lisa's question in the chat just about, do we need more research on this? And if so, what's needed? Do you want to share a little bit? I'm not sure if there's future or current work that's ongoing, building off of some of your previous work and research.
So my area of research is around task sharing and task shifting and strategies to redistribute care deliberately from health professionals to the lay public. So vaccination is part of that. And yeah, there is a program of research and a small number of people in Canada and internationally who study this sort of stuff. And I've given some examples further down in the chat. So Renata has raised the example of lay workers involved in directly observed therapy for tuberculosis, but globally, there's massive programs involving millions of community health workers in the initiation of antiretrovirals for HIV. These are all procedures and pharmaceutical processes that are at least as complicated as delivering a vaccine. And so you can see that there is a body of practice around this. And the examples, once you notice that phenomenon, just start flowing. What we do need, and what I think is present in the literature and growing, is the development of a deliberate model of practice. So, for example, we've talked about the 5 C's model or framework for vaccine program implementation. There are frameworks for the delivery of health promotion programs, but less has been developed that offers a organized framework for how do I know if there is a health problem, an intervention, and an opportunity that might lend itself to deprofessionalizing an intervention. We see it often, but we don't see organized frameworks for it. We don't see organized policy work around that. Instead, we see this sort of like popcorn type example cases and case studies around this. And that doesn't produce a body of practice. So the research that I'm involved in is to try to figure out what makes this work? What are some of the policy failures? Because it's not a panacea. It's not as though task sharing isn't without its problems. It's not as though lay workers can solve every problem in population and public health. How do we make this work? How do we know when it's not working? And how do we drive programs that are scalable and that might lead to predictable success? That's the area of research that I think is so desperately needed. Your example of naloxone distribution is excellent on this. When I trained in emergency medicine, the idea of giving anyone in the public Narcan was like, you may as well think that you were giving them a stick of TNT. It was portrayed as though you would suddenly have every person who used drugs in withdrawal, and that you'd have violence everywhere, and that it would, like, the sky would fall. That was literally how it was portrayed to me to administer naloxone when I was an emergency medicine trainee. Now the idea of inhibiting access to naloxone would be malpractice in emergency medicine. Every person who experiences opioid overdoses or is at risk of opioid overdose needs to go home with a naloxone kit. That's a successful shift. There's technological elements, there's policy elements, and there's professional elements. We need to develop those.
Yeah. Yeah, thanks for those thoughts, Erin. I think just building off of that, one of the strengths of also combating some of that misinformation that is spread is that program was actually developed in consultation and very much presented in collaboration with people who have living and lived experience using drugs. And so the material, I think, was even more impactful when presented to the students, you know, hearing some stories, doing a simulation, getting some feedback. And I think it ties in a little bit nicely with the lay vaccinator piece of, you know, it's people with experience or people who are just have that openness to learn, that I think it can be really impactful. So.
In fact, it goes even further than that. By the time we see it implemented, taught within university programs where we have students in regulated health professions accessing the naloxone training and celebrating the co-design of the programs with affected communities, by the time that happens, these programs are already highly professionalized and accepted. The genuine history of naloxone distribution programs is that it started as an act of civil disobedience. You could not find a pharmacist, doctor, nurse, or anyone else who would give people who use drugs access to naloxone, an extremely marginalized population. And it was a small number of people who took matters into their own hands, did things that at that stage were seen as illegal and unprofessional, and changed the world. And then later on, health professionals come on board, mainstream organizations come on board and celebrate that this is a co-designed intervention. But it was co-designed with resistance from the professionals at first, not with mainstream involvement. And so why do I raise this history? First, just because it's interesting to know, but second, how did it happen that the counterculture on vaccines, how did we as professionals find ourselves in the place where the counterculture on vaccines were anti-vaxxers? Rather than creating an environment where the counterculture on vaccines, where people are like, I'm going to take it home and give it to my child myself because I don't want the professional involved. I want to immunize my child in a loving home environment. I want to be a home vaccinator. How do we create through our actions, how do we either intentionally or unintentionally create a counterculture that is something that is helpful to us or a hindrance to us? I would much rather be part of a profession that created a counterculture where people were saying, I want to be a home vaccinator rather than a non-vaccinator. And I think that if we're smart, we can create that counterculture.
Fabulous. Thanks,
I just
Erin.
wanted to loop back, Erin, to the 5C. And actually, just last year, I wrote a piece along with Dr. Melissa Andrew out of Dalhousie about why we need to add another C to the model, which is collaboration, right? Because if patients see that health professionals are collaborating with each other, those health professionals are collaborating with community members, those community members are collaborating with each other, and everyone's playing from the same playbook, that is perhaps the biggest facilitator of all, right? And I think that gets to supporting that counterculture, right? Because now we're all in the same boat together. And, you know, all approaches are welcome as long as they, you know, are safe and getting, you know, the service to the people that need to get it. It doesn't really matter who does it because we're all in the same boat. And so I think that we need to really expand upon those models as well to figure out that this is no longer just a health professional doing something for a patient. We need to involve the communities. We need to involve close contacts, family members, social connections, religious organizations, everyone around somebody to support that consistent messaging. And the approach that is taken to actually get the needle in the arm is probably the least important of all of those, right? It's having that open communication and that consistency and that safety to have those discussions.
Now, this is not my area of expertise, but the other group that I would add to that collection of actors is pharmaceutical companies and device designers. Because that journey that I described around naloxone distribution started with vials and syringes and has moved to an intranasal device. Now, I don't know enough about pharmaceuticals to know, actually, I do know that some are successfully delivered intranasally, but I don't know enough about it to know what would it take to move vaccines so that it just looked different to the general public, so that it had an appeal that had been intentionally designed not for health professionals in clinics drawing these syringes up, but that had been intentionally designed for public appetite. Whole public and popular histories have been written about other pharmaceuticals moving through that journey. Naloxone's not the only example. Birth control moved through that too. Initially, when birth control was marketed, it was in a bottle with 30 tablets. Same sort of bottle that I see in the picture in Suzanne's box there. These looked like pharmaceutical tablets. It took a genius medical device company to say, you know, this should be put in something that is round and that just looks totally different and causes the target population, in that case, women of childbearing age, to say, this is something not that the male pharmacist gave me, but this is something that is mine. We have totally skipped that around vaccines, as though it simply doesn't matter. And there is no advertising or imagery of immunization that suggests to the public that this is something that you do for each other, for yourself, for caring, et cetera, et cetera, et cetera. I simply don't know where the marketing is at.
Yeah, thanks for that. And thanks, Sherilyn. I can see your response in the chat as well, just about which of the 5 C's perhaps has the largest effect on vaccine uptake. And I acknowledge that question, and also just your response earlier to the convenience, right? Access as well. So just wanted to highlight that. I can also see we are getting to the end of our time. I just did want to perhaps give Sherilyn or Rosemary a quick chance just to talk a little bit about some of the continuing education courses on vaccinations that Rosemary kindly put in the chat. I don't know if either of you want to give a quick 1 or 2 sentences about that.
Well, I'll let Sherilyn do the bragging because she is the expert author of both of the programs I put in the chat. They're freely accessible online programs, both CEP accredited for pharmacists, but available to anybody who wants to enroll. One is on protecting Canadians against pneumococcal disease. The other one, a personal favorite, vaccinations in pregnancy. Tremendous, great messaging and handouts, downloadable graphics that people can use in their practice, either for themselves or as handouts to patients. So I think they're both great programs, but I'll let Sherilyn blow her own horn on those if she wants for a second.
Yeah, it was great to release those. And like Rosemary said, they are accredited for pharmacists, but that certainly isn't a pharmacist only audience that can take them. Some of the modules do talk about scope of practice, but the majority of the information applies regardless of a person's background. So please do feel free to check those out. And we did put a lot of effort really into making sure that we had those downloadable, printable infographics that benefit both the health professional making clinical decisions as well as things you can provide to the patient. So for example, one of the handouts on pneumococcal disease is patient oriented and explains why it's more than pneumonia, why it's, you know, more than just people that are at high risk that are affected by it, why it's not necessarily a seasonal infection to the same extent as other respiratory infections. So trying to satisfy that patient need for reputable, reliable, easy to understand information as well. So do encourage anyone that's interested to check those out.
That's great. Thank you so much for sharing those. I think that is a really lovely segue into me thanking the 3 of you for joining me today. Erin, thank you so much for starting us off with your opening presentation and remarks. Sherilyn, thank you for joining us and providing, you know, another perspective to this very, very interesting conversation. And thank you, Rosemary, for joining me to co-moderate the session and just help with some of the behind-the-scene logistics. I'd also like to thank everyone in the audience today. I know we had a smaller group, but I personally am very heartened to just see the immense discussion, questions, comments, links that people posted. It always keeps our discussions very interesting and helps us all stay very engaged in this. My last sort of thought and plug is, if you liked what you heard today, we do have regular CPE speaker series events. And so next month, we have an event on the topic of labor mobility and trade agreements for pharmacy in Canada. So that's on November 6th. And then we have another event on December 4th that touches on some of the things we talked about today. And that will be about strategic placement and accessibility of naloxone kits in Canadian communities. So obviously very important and very timely as well. But I'm just seeing we are exactly at 5, so I'd just like to extend a very heartfelt thank you to each of you again today for sharing your insights and for leading us through such an interesting discussion. I hope everyone has a great evening ahead.
Thank you.
Thanks so much.